Hello, welcome to our Home Health Skilled Nursing Competency Program presented by Amity Healthcare Group. We are happy to be providing this for you. This is going to be part one, consisting of the on-demand videos. Part two will be the competency session, live interactive competency session that you attend with the comprehensive competency exam. These are some required non-discriminatory statements that we have to put out there for our accrediting purposes. And reminder that this presentation is intended for educational purposes only. The presentation may not be modified or redistributed in whole or in part without permission for Amity Healthcare Group. So let's dive right into part one. And this section is for our RN audience. If you're an LVN or an LPN, you may skip this part. It's kind of outside the scope of practice that you'll be doing in home health, but if you want to learn about it or you're working on your RN, you're welcome to join. So this will be for our RNs. And we're going to dive into OASIS-E, some of what is new. If you've been in home health, if you're new to home health, OASIS-E is the newest version of OASIS, and everyone is required to be using it as effective January 1st, 2023. So we're kind of all new to this. And we're going to go over some case management concepts for RNs as well. So might be some new content even if you've been here a bit and you're new to OASIS-E. As an RN, you are going to be responsible, potentially, depending on how your agency has you structured and what you're doing out there in the field, but RNs typically do a lot of the admission visits for home health. Admission assessments, and this is general CMS, Centers for Medicare and Medicaid requirements. A comprehensive assessment is required, and it usually consists of the OASIS assessment, which must be completed by an RN PT. OTs can now complete them. They weren't able to do that until very recently, but now they can, and speech language pathologists. So those are the disciplines that can actually complete an OASIS assessment. MSWs, LPNs, LVNs are not able to do that. So that's just kind of important to know. If any skilled services are ordered for home health, it really should be the RN completing the admission assessment and OASIS. But again, check with your agency leadership on that. That's the general recommendation from CMS. It is really important that we always understand when we're doing these assessments what our patient's insurance status is, what agency-specific policies and procedures are. The reason for that is, and we'll go into in section 2 on some of the exceptions, but most patients who are covered by Medicare and Medicaid, OASIS is required. Now, by default, a lot of private insurance companies will follow those same guidelines. And so even if someone is a private insurance pay type of situation, OASIS might still be what's required. So just always check with your office and make sure that you're completing what is required. Some agencies just do it across the board. Sometimes they don't do it for certain patients. So just know. In addition to that, it's important to know if your patient is a Medicare patient. Medicare has specific home health requirements that are unique compared to other coverage. And so, for example, under Medicare, patients are always required to be homebound. And we'll go into more detail in section 2 as to what that means. But in a short and sweet version, the patient must have a taxing effort, difficulty leaving the home without assistance. And usually it's just for short periods of time, like a doctor's office. So typically your patient is probably not driving themselves a lot of places, if at all, but we have to document that they are generally homebound, and not just at admission, but throughout. So we'll go back to that, but just file that away. The patient under Medicare must be under the care of a physician or allowed practitioner. And there is a face-to-face requirement. And some of this also applies to some of the state Medicaid rules. So again, just double check. But if you go in to do that admission assessment and you find out that your patient doesn't have a regular provider, that's kind of a big red flag. They are required under Medicare and Medicaid rules to have been seen face-to-face generally by that practitioner within 90 days of being admitted to home health for the reason that they're being admitted, or within 30 days once you're agency takes them. And if you get there and they don't have someone that they're seeing, a lot of times it's very difficult to get them in time and then to have someone who can sign your orders and your plan of care. So always make sure that they have someone current. Again, under Medicare, that patient needs to have a true need for intermittent skilled care in any combination of nursing, skilled therapies, PT, OT, speech therapy. We can provide home health aides and MSW, medical social work, as part of the interdisciplinary services, but home health aid and social work cannot be standalone services in and of themselves. So those are some of the general requirements that we need to look for. If you are new to completing these assessments, it's really good to be very well organized. If you've been doing this a bit, you probably know a lot of these tricks, but you want to call ahead of time, make sure you know how to locate the home, find out who may need to be there. If there's someone signing paperwork for them, is kind of their primary caregiver. If you're new to your agency, it's very well advised to be very familiar with your agency admission packet. The more you know what you have to go through with them and how to explain things and ask questions, the faster things will go. When you call ahead of time to prepare them for your visit, make it a point to ask them to have all of their current medications available for that visit. You are going to be required to keep a current list at all times, not just of their prescriptions, but also any supplements and non-prescription medications that they may be taking. We'll talk about that a lot some more as well. And if they're already handy when you get there, that saves a lot of time, so they're not having to look around the house and find them while you're trying to get things done. Any kind of oxygen, IV flushes, medicated skin products, those are also considered medications in home health, and we need to have those included in the orders. Again, good idea to know, do they have a medical power of attorney? Do they have someone who's making those decisions? Are the right people going to be there to sign the documentation when you show up? If you are able to review your history and physical and anything sent to your agency ahead of time, that just expedites. Walking in the house with what you kind of already know from the record will help make the visit a lot quicker. These admission assessments, comprehensive assessments involving OASIS, they do take a lot of time, and so your preparation is going to be well worth it. You'll want to find out if you know that they're going to need DME supplies, if you're going to the home to do an infusion visit, for example, or to do diabetic teaching. Are the supplies there? Did they have their IV pump delivered? Do they have a glucometer? Those kinds of things. So let's take a look at the basic elements of the admission. And the first one, the initial assessment, it's usually combined with that start of care, which is basically synonymous with the OASIS assessment and all of the things you're going to be doing. It is a requirement, a CMS requirement, that we complete that start of care within 48 hours of your agency accepting the referral. So in other words, if the agency has accepted that patient, it's not appropriate to go, say, 3 days or 4 days unless there is a provider's order indicating the specific start of care date if it's different, or it's documented clearly that it was requested by that patient, there's an order matching the date, and it is a patient-focused reason. So what we don't want to do is make it look like out of convenience the agency accepts the referral but then doesn't go in there until 4 or 5 days later, for example. Part of your initial assessment isn't just assessing your patient, it's also reviewing the home environment and anticipating your patient's needs. Does it seem like a safe and appropriate environment for home health for them as well as for you and your coworkers and staff going into that home? So if there's any red flags there, you want to talk to your agency leadership, your clinical supervisor, or the appropriate person right away. You'll be completing admission documents, and some of the typical things that are required are the consent to treat. So you'll be completing some kind of consent form. Every state and CMS requires that we give them a copy of their patient rights and responsibilities. And we have to at least ask if they have advance directives, and we secure a copy if they do. So that gets a little uncomfortable for some folks who are not used to having those conversations with patients. You're not required to, talk them into advance directives or go on a long education topic if it's not something you are trained to do, but we do want to at least give them written instructions, which are usually in your admission packet. Ask if they have them, ask if they want more information. If the answer is no, okay, that's fine, but we just have to document all of that per CMS guidelines. The comprehensive assessment / OASIS, for that, you will begin that at start of care, but you have 5 days after the admission visit itself to complete that comprehensive assessment. And the reason for that is sometimes it takes a little bit of time to collect all of the data involved. So that OASIS doesn't have to be completed the same day. You have 5 days. That gives you time to make repeat visits, talk to providers, talk to other disciplines going in the home to feel like you got all of that information that you needed. So the OASIS assessment, as we mentioned previously, it's required for all Medicare and Medicaid patients 18 and over, unless they are receiving prenatal or postnatal care, and that's the reason you're seeing them. So for example, if you're working for an agency that sees primarily pediatric patients under the age of 18, then OASIS is not a requirement. Medication profile and reconciliation. That is something that we have to pretty much work on all the time. That, even though you're still collecting the data for your comprehensive assessment, that medication profile and reconciliation should be completed by the midnight of the day after your admission. So if I admit that patient on a Tuesday, by Wednesday midnight, I should have completed that. And that gives me the time to look and see, hey, does this patient have any moderate or severe reactions with their medications, any concerns about that medication profile? So as the RN, I need to show that I communicated with that provider and let them know that and reconciled any problems. So that medication profile is a high priority from the beginning of that assessment. It is our responsibility in home health to have a current copy of the medication profile physically in the patient's home at all times. That is a big deficiency that a lot of agencies get on survey because it's really hard sometimes to control what your patient keeps in their home. So it's important that at every visit we at least ask and then we're updating that. So I can't underemphasize that enough. Development of the plan of care begins at admission. We have to show that the plan of care is individualized, specific to that patient. They're really looking nowadays that we are showing evidence of that patient, the caregiver, the family, whoever is participating and involved in that plan of care. So it shouldn't be just the goals that I, as the nurse or as the therapist, have decided are in that patient's best interest. And if your patient is capable, if you're able of even documenting goals in their own words, that goes a long way as well. That's appropriate for your patient. We want to demonstrate and begin coordination of care with the provider and other disciplines from the beginning. We'll talk about that a lot more in section 2 because that applies to everyone. Emergency preparedness, all agencies are required to have emergency preparedness plans. So that should be something that you are trained on by your agency. And we need to assess that patient's risk level for emergencies when we admit them and make sure that they have a specific plan, information, phone numbers, everything specific to their risk level. So typically agencies will rate patients from, lowest level. They can go maybe a couple days without a visit and be safe. All the way to patients who cannot go, even 24 hours without having some kind of skilled visit to keep them safe. Patient education is something that we are doing always from the beginning and documenting. The role of the RN in home health. So depending on how this agency setup is for your agency, some agencies have nurses that, RNs who do visits or assist with things, especially if you're kind of PRN or part-time. But at least to some capacity, the agency has RNs that serve as case managers. So kind of understand what your agency expects of you and what your role is based on that process and structure. But as the RN, you often will find yourself doing case management type responsibilities just by default because you're able to supervise and do different things that we'll go further into. So from a case manager standpoint, classically that means, hey, I'm an RN and I've got this caseload, I've got these assigned patients, and so I'm responsible for kind of overseeing and coordinating everything, not just performing the individual visits. And so some of those responsibilities can include any or all of the following. So it could be that OASIS assessment, which is done on admission, at recertification, different times. We'll talk about that here in a little bit. Development and oversight of that plan of care, so communicating with the interdisciplinary team. You, as the RN, might be developing the CNA or home health aide plan of care and determining which tasks that staff will perform. So the RN writes the plan of care for the home health aide, which the home health aide kind of has to follow. Either they did it or they didn't verbatim once they see the patient. And then depending on what's happening with the agency setup, you may be responsible for supervising the care provided, not only for home health aides, CNAs, but potentially for LPNs, LVNs. Now, that doesn't mean that you are, assigned to be their supervisor or their manager per se. You're overseeing the care. And what that means is, for home health aides and CNAs, if there are other skilled services involved, at least once every 14 days, you're going to be asking that patient, are you satisfied with the care provided? Let's make sure that the plan of care matches your needs. Actually supervising CNAs and home health aides in person, that's more up to the agency. In some situations, if you work for an agency where the only service they're getting, and this wouldn't be Medicare based, but if let's say it's Medicaid and they're only getting home health aide CNA, you might be making an on-site face-to-face visit every 60 days. So just important to know that. If you're supervising LPNs or LVNs as the RN, that is typically based off agency policy and state practice requirements. So if your agency determines that it's once every 30 days or once every 60 days, then that's what you're held to do. And again, you're overseeing the care, that they're happy with the care and that it matches their needs. Medication management, big responsibility for RNs in home health. And we have to do that pretty much every visit. So in thinking of the plan of care, one thing that we tend to get hung up on sometimes in home health, we think that more is better, and sometimes on survey visits, that kind of backfires on us. So when you are developing the plan of care with the patient, with the caregiver, the family, try to keep it simple in the sense that if you were to imagine your typical visit, does the plan of care, if you look at it, does it reflect what you're doing to that during that visit? So for example, if most of what you're doing with this patient is wound care and pain management, and maybe you have all these other wonderful goals that you've set on preventing falls or keeping them safe or diabetic teaching or things that you really end up not doing because maybe your focus is almost exclusively on the wound care and the pain management, that's where more is not better. So keep your plan of care specific to what you're working on with them so that it doesn't get held against you. When a surveyor comes to look at your agency, if the plan of care has a lot of stuff listed on it that you are not actually doing during the visits, that you're not documenting towards, then it looks like that plan of care doesn't match your patient. And that's how agencies can get in trouble at times. Whoops. OASIS is required during discharge and transfer. And as the RN case manager, you may be doing this, or as the RN visit nurse. Anytime a patient is discharged or transferred from an agency, there are some required elements that we need. The first is we need orders for a discharge or transfer. So make sure that you've got that. You've shown evidence of notifying the provider of what's happening, and there's an order to go with that. Then there's going to be an OASIS form, and it's typically a shorter form than what we have at admission, but nevertheless, we have to complete the specific discharge or transfer OASIS depending on the situation. At discharge for Medicare patients, if it's Medicare, they are required to receive what's called a notice of Medicare non-coverage 48 hours prior to that discharge happening so that they have a chance to dispute things if they feel like they need to. They have to have that right, so that paperwork for Medicare is required. For a discharge or a transfer, we also have to produce a summary, and we must show that we sent a copy of that summary to the primary care provider or whoever is responsible for that plan of care. So in the case of the discharge summary, we have to show that that went within 5 business days. It was completed of that patient's discharge and that a copy was sent to the provider. If it is a transfer summary, let's say it's a transfer we anticipate, we know it's going to happen, we have 2 business days to complete that transfer summary and send the copy to the provider. If it ends up being a transfer that we didn't anticipate, let's say you show up to see your patient on a Wednesday and you find out from the family that they were transferred to the hospital for an emergency on Sunday and they were admitted. Then you have 2 days from becoming aware of that unplanned transfer to complete your OASIS. And a transfer can occur with or without a discharge. So if both happened, you have to kind of do both, right? Transfer and discharge. What are reasons why we transfer or discharge a patient? Best case scenario, goals are met. Patient did great, everything worked out, yay, they get to be discharged. Sometimes transfer or discharge can happen per the patient's request. Maybe the patient decides that they don't want or need home health, even though we feel otherwise. Maybe they're not happy, they have complaints towards the agency and they want to transfer somewhere else. That's an example of a transfer or discharge per patient request. Sometimes a change in condition necessitates transfer and or discharge. All of a sudden the patient is too sick and not safe to be at home and they have to go to the hospital, or they're no longer safe to be in a home health setting and they need to go to a skilled nursing facility. In that case, they can't have both. We would have to discharge them from home health for admission to a skilled facility. A death, whether it's anticipated, not anticipated, obviously that's going to be a discharge, and then OASIS has to be completed for all of these examples. Our documentation needs to demonstrate that whatever the reason for the transfer or the discharge was, that it was patient focused and never for agency convenience. Okay, so that's really, really important. And so let's talk a little bit now about OASIS and what is changing. So as I mentioned, January 1st, 2023, everyone's required to do OASIS-E. We've already kind of hit some of the common times that OASIS is required, but let's summarize that again. At start of care or admission, transfer with or without discharge from the agency, a resumption of care, meaning that maybe they went to the hospital or somewhere for a bit, they came back to us, but we never actually discharged them. So resumption of care, ROC, and then discharge from the agency or a death. So those are different times when OASIS has to happen. So whether you're new to OASIS or you've been working with it for a bit, reminder and or FYI, OASIS assessments are all about data. And these are some of the different uses of why this tool is designed. Again, it is CMS requirement. It's part of the conditions of participation. So if you are working for an agency that is Medicare, Medicaid certified, under the conditions of participation, they have to collect OASIS data. The OASIS questions are geared toward all kinds of quality measures and processes, and so it's a way for your agency to be measured against the national average. Some of that is tied to reimbursement, as we're going to see, which is why it's important that we complete it accurately. It's used to measure things like resource utilization, identification of patterns of fraud and abuse can be looked at that, and then value-based purchasing, which is a very, very big thing because it is tied to how your agency gets reimbursed. So linked to that value-based purchasing, everything that you do and everything that you document and how your quality measures look, they can affect how your agency is compensated up or down by as much as 5%. And for some agencies, that's not a lot of wiggle room, and it can really detrimentally affect the bottom line. So we always want to be honest and accurate, but that accuracy is highly important because we don't want to accidentally show that patients are, doing worse when they're not because we didn't answer our questions correctly. So based on your responses to the patient's baseline status is how this is going to look. So when you answer these OASIS questions, make sure that you're not focusing just on what's happening in front of you at that particular moment in time. Also take into account, what is the baseline? How are they usually doing things? And that may require that we use family and caregivers as sources of information. It may not all be right in front of us at the visit at the time. When OASIS questions ask you how much assistance the patient needs, they're referring to what they need from another person, not from an assistive device. Okay, so when they're asking you if they're able to bathe or turn and those kinds of things, try to kind of see what can they do on their own with or without the assistance of another human. These are all of the current sections of OASIS as of this time. This is very different than the way it was before. So if you're new to OASIS, it might be a little bit easier because you don't know what else to compare it to. But if you've been doing OASIS, you probably remember it was all a bunch of M numbers. Now we've got everything from section A through Q. Okay, there's not all the letters represented. But just kind of as you work your way through it, kind of focus in and hone in on all of this to kind of retrain your brain. So let's hone in on what's different about OASIS-E if you've been working with OASIS, the last version, which was the OASIS-D. There's a heavy emphasis now on social determinants of health. And if you're not already familiar with what that term means, the government is collecting, CMS is collecting a lot of information on this because it has been proven through research that social determinants of health are heavily linked with health outcomes. And so things such as, do they have access to quality of care? What is the health literacy and education access? What is the neighborhood and the built environment like? What social and community resources? What is their level of economic stability? So a lot of the questions that you're going to gather data on have to do with this, especially in that first administrative section. That section A is where you have questions on ethnicity, culture, preferred language. Patients don't have to answer any of these questions, just so that you know. So there are options where you can indicate that they refuse to answer. But we need to at least try to collect this data on a regular basis. And so not having that information should be an exception, not the norm. There is a section specific to health literacy as you move into the section B. And question B1300, how often do you need to have someone help you when you read instructions, pamphlets, other written material from your doctor or pharmacy? That is how we gauge health literacy. Social isolation is a big one because we have found that folks who identify as being socially isolated have more negative health outcomes. Something that is really new if you've been doing OASIS is in section C, when we get into cognitive patterns, the BIMS, the brief interview mental status. Really take your time getting to familiarize yourself with this. The BIMS kicks in beginning with C0200, and you're going to be asked to ask your patient to repeat 3 words back to you. The words are sock, blue, and bed. And you're simply going to ask them that. You're going to see if they're able to have short-term memory recall, repeat those back to you. There'll be a question on temporal orientation, the typical, do you know what year, month, and day it is? And then as you move forward with the assessment, you're going to end up asking them about recall. Do you remember those 3 words that I asked you to repeat to me a little bit ago? And then you're going to assess how many, if any, of those 3 words they can remember. So all of this is going to have you come up with a score. If the patient can't complete the interview, there is an option to enter 99. And what we're doing here with this section C and with the BIMS is kind of assessing to see, where they are potentially with risk for undiagnosed dementia. Information, it isn't a diagnostic tool, but it's a screening tool. And if we have a certain score, we're going to want to communicate with the provider on that. Section C continues to ask questions specific to delirium, acute mental status change, confusion, anxiety. Do they have a potential cause like an infection, an active infection? Do we need to try to figure out what the cause is? So again, this is going to be new to you if you haven't been doing, none of us have been doing this, right? Because it's new. So you'll want to really take your time with these questions. Be very cognizant of your patient's dignity and privacy. Remember to consider baseline, use caregivers and family as appropriate, and just try to do your absolute best with this. Section D is going to take us into mood. If you remember, if you worked with OASIS-D, we had the PHQ-2 questions, which were kind of a preliminary depression assessment kind of thing. So what we're doing now with OASIS-E and Section D is we're going a little bit deeper. So those PHQ-2 questions are still part of the assessment. And if it seems like it's not indicated to go further, and you'll know because if there is a frequency score of 2 or 3 when you rate things on symptoms, if they have symptoms, you're going to be prompted to continue the assessment all the way through PHQ-9. So there's going to be more questions. And again, we want to respect their privacy, take our time, respect their dignity, consider baseline. 99 means, you couldn't complete. Maybe they weren't able to have conversation or they weren't of a cognitive status to do this, but they're making us go deeper into mental health assessment and screening. And then in D0700, you've got that social isolation question. How often do you feel lonely or isolated from those around you? Section J is all about health conditions. So under value-based purchasing, avoiding hospitalizations and ER visits is going to carry 35% of that weight for value-based purchasing, which goes back to that reimbursement rate, that 5% up or down, right, that your agency is going to have to be responsible for. So what that means is they are actually, in those first 60 days of admission to home health, holding the agency accountable if the patient is hospitalized or if they have to use the ER. So it is critical that as clinicians, we accurately assess their risk for hospitalization and work with the interdisciplinary team, meaning the team you work with or your agency, the providers, everybody involved in the care, to manage the patient's hospitalization risks. The big three areas for risk are pain, uncontrolled pain, poorly managed pain, falls, and dyspnea. And so OASIS-E is going to take you into some questions regarding that. So if you identify that the patient is at risk for any of this, as a team, we have to ask ourselves and work together, how are we going to keep this patient out of the hospital, away from the ER, so that we can have best outcomes for them and best outcomes financially for the agency? It's important that clinicians and agencies organize to get that accurate history, because you know what? If I don't know that the patient is at risk for these things, I can't plan for that. So getting those accurate documents, asking all of these questions up front is critical. In OASIS-E, we now have a section, it's in the N section, so N0415, is high drug classes. And we're going to collect this information at start of care, resumption, and discharge. So not only are we getting all of their comprehensive meds, we're also going to ask about these high-risk ones. And we want to find out if the patient is currently taking these or if there seems to be an indication for these and maybe they're not taking them. And so the classes include your antipsychotics, anticoagulants, antibiotics, opioids, antiplatelets, hypoglycemics, including insulin, and there's an option for none of the above. So maybe your patient isn't needing or on any of these, and then you would select none of the above. But you're going to have to select, where they fall in terms of being on these, needing these, or any of that. And then what do we do with all of this information? So again, we're identifying risks and needs for resources proactively. That BIMS tool gives us useful information as to whether patients need follow-up for possible dementia screening or diagnosis beyond what we're doing. We want to increase referrals to our MSW that the agency should have access to, identifying community resources. Again, how do we prioritize care coordination and collaboration to manage hospitalization and ER risks? That's really what this is about. So it's almost like agencies have been given the hint that, hey, as you take these patients, this onus, this responsibility is on you to keep them safe and managed at home as best as possible. Of course, it's not always going to be possible. We want to use the updates in OASIS-E to improve quality outcomes from our patients because we're getting all of this valuable information. And that's really at the end of the day what this is about. Okay. So thanks for listening in to part 1 RNs. I will see you in part 2 momentarily.